This training was supported by the CDC, and the contents are the views of the authors and do not necessarily represent the official views of the U.S. government.
Thanks so much, Amy. And I really want to echo gratitude for everyone for joining us today. We're really excited to have you with us. And we're excited to have this conversation. So my name is Liz Olson. I am a senior policy analyst with ChangeLab Solutions. And as Amy mentioned, I'm going to spend just a few minutes here at the top of our session to introduce two new resources that we've developed with support from CDC and in partnership with the Network for Public Health Law. Then I'll turn it back over to Amy, who will unpack some of our key themes that emerged from that work. And then we'll turn to our guest speakers, Hayes Stridicus and Dr. Kapunan, to talk to them about some of their experiences working to actually implement policy in their school community. So first, in case you don't know us, I'll introduce ChangeLab Solutions. We're a nonpartisan, nonprofit organization that uses the tools of law and policy to advance health equity. We partner with communities across the nation to improve health and opportunity by changing harmful laws, policies, and systems. So today, as I mentioned, I'm really excited to introduce two new resources that we've developed, again, with support from CDC and in partnership with the network. They highlight state and local policy strategies to reduce overdose and other drug-related harms. The policy guide, which is pictured on the left of this slide here, highlights a range of state and local policy strategies, outlining the details of potential options for new policy or changes to existing policy to help mitigate the overdose crisis. The companion implementation resource, which is pictured on the right, offers guidance on the policy process, aiming to support readers to put those strategies into practice on the ground. So the policy guide is sort of the what, and the implementation resource is intended to help readers think through the how. Those are both available on the ChangeLab Solutions website, and I will share a link in the chat in just a moment. So in addition to those two resources, I also want to name that another resource was developed by our partners at the National Association of Counties, NACO, for this project. That resource highlights 5 counties that are using opioid settlement funds to advance health equity and details some of the steps they've taken in the early years of payments and highlighting considerations for other localities. So that resource is available on NACO's Opioid Solutions Center website, which also houses many other really excellent resources to support local leaders in their prevention and crisis response work. And I will share that link in the chat as well. So for a bit of context on how the policy guide and implementation resource were developed, I'll share that our team used a couple of different methods to identify the strategies outlined in the documents, including first an initial scan of peer-reviewed and gray literature to identify existing overdose prevention policies implemented in our 4 focus sectors, which are schools, healthcare, criminal legal, and community. We also conducted interviews with 22 experts across those sectors who work in a variety of state and local contexts across the nation, including as researchers, as healthcare practitioners, policymakers, community-based organization, government agency staff, policy advocates. Many also shared their perspectives with us as people with lived experience, and we're extremely grateful to each of them for sharing their expertise with us. Their insights are really foundational to the materials, and you'll hear some of their quotes from Amy today. We also conducted an assessment to screen policies across a range of impact and feasibility criteria, including strength of evidence, ability to advance equity. And that assessment helped us to generate kind of the final group of strategies that are highlighted in the guide. Okay. And on this slide, so the policy guide introduces each strategy. It briefly reviews relevant evidence and considerations for how the policy can be designed to reach people facing particularly elevated risk, including folks who are currently or formerly incarcerated, people who are pregnant or postpartum, people who are unhoused. And it highlights an example in action at the state or local level. The implementation resource on the next slide is intended for readers who might be less familiar with the policymaking process. It outlines some key steps to putting policies into practice and kind of shares guidance for identifying needed interventions in your community, advancing them through the adoption process, and implementing them so that they create meaningful change in people's lives. So today's conversation is the last in a 4-part webinar series, each one focused on the 4 sectors that I mentioned we explore in the resources. And so today's focus is on policies that can be implemented within kind of school and school systems. So we're very honored to be joined by Dr. Kapunan and Hayes Stridicus, who will be sharing about their work to expand access to naloxone. And I do want to mention that recordings of our other sessions in the series are available on the Network for Public Health Law's website, and we encourage you to check those out to hear the other conversations we've had with some great leaders working in community healthcare and criminal legal settings who are working on a range of different policy strategies from overdose prevention centers to medications for opioid use disorder treatment, expansion, and access. So we hope that these materials and this conversation will be useful in your work, and we're really excited to engage with all of you. So thank you so much again for joining us today. And with that, I will turn it back over to Amy. Thanks.
Thank you, Liz. Okay. So throughout the work that Liz mentioned, through our interviews with key informants in each sector, several themes became apparent. And I'd like to go over a couple of them and show you a little bit about what our informants were discussing. So first theme is that law and policy changes are critical to making progress in overdose prevention. People really emphasize the need for structural change. For example, one informant said that many of the things we're dealing with are the results of or exacerbated by wealth inequality. Navigating the harm that poverty has on the people we're trying to serve and keep safe is impossible. If there's a way of doing a better job of being more loving and caring, then that's what we should be doing. And I feel like access to healthcare and alleviating poverty, creating community, these are all the pieces that need to come together to support people in their lives. Sort of a corollary to that, existing law and policy may pose a barrier to overdose prevention, and that we need to end the criminalization of the person. One informant said that the way that we criminalize people who use drugs acts as a disincentive for them to be able to get treatment and ensnares them in the criminal legal system, which just makes it harder for them to get well and more likely for them to die from overdose. Substance use disorders should be treated as a medical condition first. Many of our informants pressed the need for healthcare to be evidence-based. And in fact, one shared the story that they'll never forget the case of a woman who was pregnant and didn't want to try medication treatment because she knew that it would lead to a child welfare filing at delivery. And she overdosed, and both she and the baby died. Another theme was that overdose prevention is distinct from recovery needs and treatment of substance use disorder. Really, we need to emphasize supporting both those in recovery and those currently using drugs. Many times this gets conflated, or the people who are currently using drugs get forgotten about entirely. One of these policies could be overdose prevention centers, and one of our informants discussed that we know from other countries that have overdose prevention centers in place that they seem to be effective in terms of reducing overdose and other harms associated with drug use without any consequent harm to the surrounding community. So especially with the lethal drug supply we're seeing in the United States, offering a place for people to be able to consume drugs under supervision so that overdoses can be intervened on early and where their drug supply can be checked is critical. Structural racism is a significant driver of inequitable outcomes for drug policy. Truly, we need to address the racist basis of the war on drugs. That's where it came from, and it still is an extremely racist policy. And it affects our communities of color more than in more ways than just criminalization. For example, there's too many communities in this country where calling 911 for a medical emergency is synonymous with calling the cops. And if law enforcement is the first responder, or the idea that a cop could show up before the ambulance comes, sometimes that can be enough of a deterrent that in that moment of an emergency, people will not call 911, which can contribute to death because their fear of interacting with the police. Drug overdose can often be best prevented by addressing the social determinants of health. Drug use is often an outcome of poor health and poor access to resources, not the driver. Um, we had several people talk about the housing first model, where people with substance use problems and housing instability are offered housing and not kicked out of housing because they continue to use. The model seems to be effective in ensuring they're retained in treatment and receive other services, and just the opportunities to place people in housing have broader, longer term consequences for their health and their mental health. And we also had many of our informants, in fact, all of them, stress that lived experience is key and living experience. As policymakers, we need to listen and hear the people with lived and living experience, put them in the driver's seat, and build out from there. And of course, financial issues always arise. Sustainable and attainable funding is essential for implementing policy solutions, especially for employee stability and retention. We had one of our informants point out that funding and grant contracts operate on a very short cycle. So you're constantly sort of chasing your tail, and there's not really any sustainability to the program. You're hiring people who don't have a lot of job protection, and you're always at the whims of administration changes. If you think about it, that's not the way we do cancer care. If our oncology model changed every 4 years because of funding, that would be a completely ridiculous way to deliver healthcare. And it is in the case of drug use as well. So some example policy strategies that we identified from this project for schools that are rooted in harm reduction would be increasing mental and behavioral health services within schools, naloxone access and naloxone, the ability for students and teachers to be able to carry naloxone, expanded SBRIT, screening behavioral, screening, brief intervention and treatment, and decriminalize these next three I added on here. Those are not particularly identified as school policies, but I think that these policies will affect the home life of our students in a way that will make it easier for them in schools, which is decriminalization of drugs, housing first policies, and guaranteed basic income. There's a wide variety of choices based on the context and the needs in your area, but there's never going to be nothing that you can do to increase access to harm reduction policies and prevent overdose. So talking about SBRIT and some other mental health support in schools, it can identify students at risk of SUD and overdose to connect them with harm reduction and treatment options. School-based universal interventions improve students' attitudes about themselves, others, in school, increase pro-social behavior, and reduce conduct and internalizing problems. School-based mental health services reduce barriers like transportation and parent work schedules and increase access to care. But discretion needs to be used to ensure that these screenings don't increase harmful interaction with law enforcement or result in increased exclusionary disciplinary actions. It shouldn't be another way to criminalize the student. So in our implementation guide, we talk more about the policy process. At all times, we encourage you to include people who use drugs and other community members to make sure that they're involved and engaged, because they're the people that know what they need the most and what will help their community the most. Making policy without engaging those people is likely to result in a policy that does nothing in the end. So identifying and defining the problem, envisioning and planning for success, reviewing and selecting a policy, developing and adopting the policy, and implementation and evaluation of the policy. This is the cycle. After you evaluate, you can identify any more problems and continue around the cycle again to implement more policy or change the policy that you have implemented. In policy selection, some key considerations are how to identify and prioritize policies needed to mitigate overdose in their community. Highlight key steps. The guide highlights key steps to consider in selecting which evidence-based, equity-centered strategies to pursue. The guide also discusses in policy adoption what strategies can be employed to move from a proposal to an actual policy change, including offering information to support strong policy design and how to move it through the adoption process. And then the third section is on implementation. What practices can help ensure that policy change, once enacted, translates to meaningful outcomes in people's lives. The guide provides guidance to ensure that once a policy has been enacted, it's implemented and enforced in ways that achieve its goals. To focus on implementation for a moment, we discuss focusing on our key partners, nothing about us without us, centering people who use drugs. In certain situations, like we are going to talk about in schools today, it might not be the kind of people who use drugs that you may be envisioning, but to think about really who in your community is at risk for overdose, and who will benefit the most from a policy. Education and outreach. The guide discusses coalition building, community support, messaging, and outreach. It also discusses how important it is to think about how the policy will actually be enforced in different communities and whether that enforcement will be equitable. And finally, it discusses how critical it is to have an evaluation process in place from the beginning in order to have accurate information for the future of the policy. So now I'm going to talk to our experts today. Again, as Liz said, we have Dr. Patricia Kapunan, pediatrician and school health expert, and Hayes Striticus, a student advocate, both involved in changing naloxone policy in their schools. 2 different school districts, 2 different communities, and I think it'll be really interesting to hear from them their process and how these processes may have been different. So I'm going to stop sharing my screen now so we can talk to our guests. Thank you so much for joining us today. I would love for you to introduce yourselves and just give us a little bit of background. We'll start with you, Dr. Kapunan.
Thanks so much for having me today. My name is Patricia Kapunan. I'm a pediatrician and teen health specialist. And for the last 2 years, I served as the chief medical officer for the largest public school system in Maryland state. So as the medical officer, my job was to think about health strategy at the district level, how to help keep our students and staff healthy within the work of our school system, and to ensure that health needs or health status or health risks were not a barrier to engaging at schools. And just a little bit about our county. Montgomery County is the 14th largest, was the 12th most racially and ethnically diverse county in the country. It's the 14th largest school district in the country, the largest in the state of Maryland. As I said, we have 211 schools, and that includes 26 high schools, over 160,000 students, so pretty large. It's also the home of institutions like the NIH, the FDA, the Health Resources and Services Administration, HRSA, and the Substance Abuse and Mental Health Services Administration, SAM. So you can understand it's an interesting place to do health policy. It's a place of incredible wealth, incredible need, and lots of opportunity.
Thank you. Hayes, do you want to give us a little background on yourself and where your policy change was instituted?
Of course. My name is Hayes Striticus. I just completed my freshman year at the University of Richmond, go Spiders, and I'm a proud graduate of Durango High School. I'm from Durango, Colorado. We're a rural school district in the very southwest corner of the state of Colorado. A bit of background about my policy experience. In 2021, we had a fatal fentanyl poisoning in our community. The state of Colorado, according to CDC data, has a adolescent overdose rate of more than 2.3 times the national average. And that was something that's definitely being felt in my rural community. And a group of students, including myself, came together and founded the organization Students Against Overdose. And we were looking at saying, how can we prevent the next overdose in our community and how can we save lives? And that brought us to both fentanyl test strips and naloxone. Most school districts across the nation have a de facto ban on any naloxone products, including them in bans on over-the-counter products, as well as school administrators and school law enforcement seeing naloxone as a sign of drug use, which really stigmatizes student carrying. We sought to change that. That picture you saw earlier was actually us in front of our school board chambers, rallying and protesting for our district to allow students to carry naloxone, as well as allowing naloxone education. After we changed that policy at our school level, we then lobbied House Bill 24-1003 at the Colorado state level, making Colorado the first state in the nation to expressly recognize students' ability to carry naloxone and fentanyl test strips on school campuses, as well as encouraging districts to include that in drug education curriculum. So that's kind of where we are now. our policy change was really born out of loss and born out of looking at what are our experiences and how can we make sure the system of drug education and the system of education guarantees student safety and can work for us.
That's amazing. Thank you. And I know, Dr. Kapunan, you've discussed with me before that that there were students in your district as well that were asking for this policy change. So I love that both of these policy changes are student driven. Could you tell me a little bit more about that, Dr. Kapunan?
Yeah, absolutely. And thank you, Hayes. He captures so beautifully that there is a lot of urgency that you feel about this particular subject. And we don't always hear that, I think, at the policy level. In Montgomery County, which is much of it is urban. We're right next to DC, where some of it is in the Beltway. We were not, there were overdoses happening. You know, we're right next to the District of Columbia, and we had already seen this pattern with our own county. It was not that different from what we were seeing across the state's neighboring county, in a rise in youth overdoses due to opioids, as well as youth deaths. From 2021 to 2022, and then we saw that same pattern in 2023. But in December of 2022, more data were coming out that were very validating of our experience in terms of medical literature, the CDC monitoring the future, all these studies that showed that the use of illicit fentanyl as behavior was on the rise, that overdoses among youth were on the rise. And this was a little bit not unexpected for people who are living it on the ground. But coming out of the pandemic, there were some views that youth substance use was actually going down, that the opioid crisis in general was not as much of a problem. But when you pulled out youth, there was something happening in terms of access to illicit fentanyl, accidental exposure, as well as intentional use. And it all kind of converged that winter for us. That we moved from awareness to taking action as a community. And one of the first things we did was have a huge community forum where we just listened to people, brought various experts in the community who were working firsthand. You know, that included not just schools, but fire and rescue, our health department, our police department, and just engage with the community. And how are you experiencing this? What questions do you have? And it was eye-opening because instead of just, an awareness, we realized that there was this huge spectrum of need and experience, from parents who were like, is this really a problem? This can't be a problem, to parents who are, you got to help us. We're on our third residential treatment center. And, I'm sending my kid out of state and it feels like nobody's listening to us. And youth came out hard. They said, we want to be a part of this. We're seeing our friends, we're seeing family members. At that point, we were campaigning on Narcan as something that everybody needed, right? So not just for illicit use, but prescription use, that this was something that parents needed to know about, people who had prescription medications at home, and youth. So our health department, who was very youth forward, we partnered with them in bringing Narcan training to these huge community forums. And we didn't say this is for students. We said this is for everybody. Everybody has a role. But the students came in droves. We had to put them at the front of the line because we were running out of Narcan. And they were the ones who said, we need a policy that says we have to carry it in schools. We are able to carry it in schools. And we didn't have a policy that said that they couldn't. There are some policies that are already exist in schools with regards to being able to carry a medication, but really no precedent for a policy where a minor can carry a medication that they might use to save the life of another child. So it was this is like the space where you don't know how laws and policy actually impact youth and student behavior. And until you truly engage in those conversations, you're not sure what that policy change will look like to support what they need to be able to take care of themselves. And it's something that we felt strongly about amongst our partners, the health department, the police department, because the overdoses we were seeing in the community were not happening in schools. They were happening outside schools. In Maryland, every school since 2017, Start Talking Maryland Act was required to have naloxone. So we had already had procedures for naloxone, even down to the elementary schools, and we already had it in the schools. But when this happened, we started talking about how to use it, how to get it in the community if you need it, who should be carrying it in the schools. And then part of that was really supporting youth to be able to carry it outside the school day, because they were much more likely to be able to need to intervene when they weren't in school, if that made sense. And I think it wasn't clear to people that they really needed to see that in writing, and we needed to understand what the technical difficulties, if you will, were in how they were experiencing barriers to accessing and carrying and training.
Thank you so much. You had mentioned that Montgomery County is very wealthy, and that some of the pushback, not pushback, but the concerns you heard from the community were like, well, is this really a problem? Like, is this really happening here? I imagine the concerns from the community in Durango were different than that. Hayes, can you talk a little bit about what you heard from the community that was maybe putting up a roadblock in your activism, or what people were saying that they didn't want you to be able to implement this naloxone policy?
Yeah, definitely. So, like, considering that the impetus of this was a 15-year-old child dying and, 2 others being put into an ICU, we definitely could convey a sense of urgency. But simultaneously, there's, we go back to this inherent racism and classism that really impacts public health and really impacts public policy. And you see so many people saying, well, that couldn't be us. That was the charter school. There's 2 high schools basically in Durango that service about 1,600 students combined. And it was like really pointing out that this is something that impacts all students in our district. Our district's own surveys point that 20% of students by the time of graduation will have tried a narcotic harder than marijuana or alcohol. So we have this urgency of this problem, but it's convincing people both that naloxone and other harm reduction methods are the proper response, as well as convincing them that addressing this problem is what they should be doing. We had initial concerns from our school district of, if we address this problem, it looks like we have a drug problem. We're like, well, sorry, we got news from you. You definitely do. And I think it's, regardless of your overdose rate, regardless of your drug use rate, if it's higher than the national average or below it, it's still an important policy. For us, the way that we kind of overcame this hesitancy, these people saying, oh, we'll encourage drug use, it will normalize drug use, was looking at naloxone and harm reduction in the school setting as an educational opportunity. A lot of us are still receiving this very backwards and antiquated war on drugs era education, which looks at drug use in a community as a criminal problem, not a medical problem. And the impacts of that mean that students do not feel comfortable, whether that be seeking help or discussing drug use or addiction in a school setting. And it's looking at naloxone, because that was our main focus, but as well as other harm reduction treatment options, as a way to engage students into a proper medical system. And I've said this before, but I think carrying around naloxone, carrying around these reminders of how dangerous this drug supply is a far better educational tool to convey the danger and convey the urgency of this problem than playing a video of a frying pan hitting an egg and saying, this is your brain on crack. It's how do we use this distribution of naloxone and this engagement with harm reduction as a second opportunity for drug education for many students who feel alienated and who feel isolated, and to show them that we can create a system of compassion and of care that can lead to recovery and more positive outcomes.
Thank you. That's really, yes, thank you very much. I'm very amazed that, not amazed, I'm always impressed with the youth advocates. And I think this sort of goes into my next question, which in most of these has been, how did you center people who use drugs in the policy process? But in this situation, while of course this is about saving the lives of youth that may be using drugs or other people in the community, right? Because if you're carrying naloxone, it's not, you may save the life of someone that's not in your school. But I think that it's, like you said, like both of you said, it can be difficult to admit that students are using drugs, and that is the reality for many people. And those are the folks that it sounds like you really, it's the students that were centered at this. And I see that there's major student advocacy um, both angles here. And I'm interested Dr. Kapunan, if you could talk a little bit more about how you were able to make, while this was, the policy was to allow students to carry naloxone in schools, you made it about the community. So it seemed a little less like we're admitting that students are using drugs, and more about this is important for everyone. Could you talk a little bit more about that?
Yes, and let me just quickly correct something.
Yes,
We
of
talked
course.
about earlier that Montgomery County is a wealthy county. It has a wealth of resources, including its considerable diversity, but it's also a destination county. For example, we welcome many international families who are new to this country. So we have this challenge of scaling and having a wealth of resources, but also a lot of opportunity at the same time. So from a policy perspective, scaling means you have to meet all needs, right? And it's the same thing when we're talking about who you center in your public health initiatives. Being youth-centered, I think that there's an essential problem when we say, how do we center around people who use drugs, right? Like, especially when we think of youth prevention, there's not the prevention and then the recovery. And then, so it doesn't flow entirely like that. So for youth, prevention strategies at every stage are really critically important. And supporting the people who support youth, trusted adults, is critically important. So listening to their stories, teachers, security guards, parents, friends, peers, all of that is really important when you're trying to build a comprehensive youth-centered model of a public health initiative. And in schools, sometimes they wait till you get into trouble to connect you with a resource, right? Like, oh, let's identify the kids who are using drugs. When they get caught, we're going to, do this particular type of discipline or do this particular type of support. And that's not where we were. We were trying to treat a complex human problem with a coordinated, comprehensive, community-based solution, right? And trying to not hit, but think of the whole spectrum, using a public health strategy of prevention, folks who are not using, understanding what the problem is, finding who is at risk, reducing risk along the different areas, and even thinking about people who had losses and were grieving, and what kind of supports they needed, as well as students who were actively in recovery. So when you think about doing things from a youth-centered, centering youth, I think means listening to everybody who supports youth as well as youth. And it also means meeting them where they're at. So one thing, and I actually have one of my partners, I see he's in the audience, Ben Stevenson II, who is the director of our prevention and harm reduction services here in Montgomery County. And I've learned so much from him, and just in terms of his approach to youth. So one thing is, when we did adolescent substance use prevention groups in the schools, they were voluntary, right? You didn't get assigned. You didn't have your counselor make you go. It was something that you could sign up to. You were interested. Maybe you had a friend, and kids just showed up in huge numbers and asked for more and more sessions. But the idea of being able to choose where you engage in this process, and understanding also that all the different risk factors really are rooted in things that we can support youth with in schools, in terms of mental health, in terms of needing to find purpose, needing peer support, or some unmet need that places them at increased risk for behaviors that may be harmful. So like understanding that there was this comprehensive prevention that needed to be done, and you didn't necessarily need to pick out the people who are actively using drugs to make an impact on the culture of use. And then to also not just focus on what not to do and harm reduction, but sustainable change through building a new culture, cultivating purpose, cultivating skills. And I think the other thing you said is we made it into a big community thing, right? So we didn't think of Narcan as, okay, we're giving naloxone to students. We thought of it as everybody needs it. And everybody is part of the problem, and everybody is part of the solution. And I think that that really helped. Like, save your buddy's life, save a student is what the students named their intervention. And Mr. Stevenson started our youth ambassadors program, and now there's so many students who are not just they're training other students to do Narcan, training other students to be advocates. So that like first bit of permission and making sure that everybody understood it in this huge comprehensive scope of what the problem really was, I think really empowered both parents and students to be active in a bunch of different lanes when thinking about opioid use and overdose prevention. Does that answer your question?
Yeah, I think so. And I actually have one more question I want to ask Hayes before I open it up to questions from the audience. But I did notice one question that's already in the Q&A box that I think you can continue on this about can you envision schools serving as a community hub for naloxone distribution and education? And isn't that what you said, how you did the distribution, right? You opened it up to the whole community, right?
So schools sometimes are the largest place in the community for people to congregate. That's like true in my own neighborhood where it's like the biggest building. So if you want to do a flu clinic, that's where you can do it, right? And we have high schools here that have 2,000, 3,000 students in them. So they're naturally places that are large in their spaces, but also where many of our community members interface with county organizations. So there's nothing that we can't do everything for kids alone. There's a narrative in schools right now that we are to be psychologists as well as educators, as well as lawyers, as well as that, feeding kids. And that can be very overwhelming for schools unless you stop and take a look at all your partners around the county and the community who also are really invested in children. So you can't do that, but schools can be the place where people access that, learn about that, because they are already there every day. They already trust you with their children. So why not engage and help them access resources and partner with other people to bring that to the school? Does that make sense? So I think they can be hubs, but it really is a partnership and doesn't just belong to schools by any means, especially when you think about things like equity in treatment, access to resources. That is certainly beyond what we're able to accomplish in schools.
Mm-hmm. Thank you. Hayes, the question I wanted to ask you, it's not exactly a question I sent you, so I apologize in advance, but I was thinking about what Dr. Kapunan was saying about speaking with the students, but also with teachers and other people who are close to the students and can speak for what they are noticing and need. Who were the partners with your organization involved in bringing the legislation to the state? Like, who did you go to first? Who were the people that were your champions?
Yeah, definitely. We were incredibly fortunate to have Representative Barbara McLaughlin. She's our local representative, and we worked with her to write this bill, which was a very surreal experience for all these students to go from their beginning. We started this literally driving friends to public health offices and just going, we need to get more Narcan out, explaining how to use it to peers, distributing before we had a policy from our school district because students were not going to wait for another death to spur action. And we realized that this was something we needed to make sure was not just happening in Durango, but was happening across our state and hopefully nationwide. We're looking at some legislative partners in other states to hopefully introduce similar bills and similar legislation. I know states like Washington and Maryland have similar legislation that has come independently, which I think really speaks to the urgency that youth are feeling across this nation. We partnered with a lot of public health groups. We're fortunate to have a lobbyist represent us pro bono, and really looked and took a step back and said, how can we generate a coalition of agreement and understanding? And there's pretty funny. There's some groups which we don't think have ever been on the same fact sheet before for a bill that we managed to both make agree to this. The final margin in the state Senate for our vote was 1-34 in favor, 34-1. So it's how do we really present this as a nonpartisan health issue whereby the government should give doctors, public health specialists, and those with lived experience the autonomy to do what is best for them? And how can we put government in a supporting role to this? For us, that looked like we engaged with a lot of educational organizations. So that'd be like the State Association of School Boards, various teachers organizations, as well as medical groups. Colorado has a very interesting history with drug culture, obviously, as one of the first states to legalize marijuana, but also looking at these very isolated rural towns where you get kind of unique cultures of use developing. And it's how do we make sure that we engage groups that have lived experience to pull that in. Something that we had was, the needs of a district like Denver or Aurora is very different from the needs of a district like 9R, which is my district. And it was how do we kind of pull in partners from the Front Range is what we call it, but more of the urban centers, and make sure that we get, homogeny with what's a policy that will benefit everyone. So that was something for us, is really pulling in as many school organizations and public health organizations to kind of make sure that we can guarantee a proper kind of exchange of ideas and exchange of information. And a lot of that came through students in different districts and saying, well, what would you like to see and how would that work? And that's something hearing about Montgomery County is so incredible, is their ability to pull in students. And it really shows that when you create the structures to allow students to engage in public health, to allow students to engage in these crucial programs, they will come. And that's where it's so important that school districts like Montgomery County Public Schools engage students, and why it's incredible to see school districts doing such great work.
Thank you so much. I really appreciate it. And I do want to give some time to the questions from our audience. I apologize in advance. I may not be able to get to all of them. But if you have any unanswered questions that that I don't get to today, or if you have any specific questions for our panelists that you would like to be able to be put in contact with them later, you can email me. I will put my email in the chat, and I'm happy to help you with that in the future. But to start, I wanted to ask actually for both of you. Dr. Kapunan actually answered that in the chat, in the Q&A. Sorry, someone had asked about how to get the supply for community distribution or for the students. And Dr. Kapunan said that Maryland has a state program that an organization can register to be an overdose response program. So the health department had the designation, and last year the system applied for this status. Hayes, were you able to get the actual supply of naloxone in your schools, or was it just the allowance for carrying naloxone?
Yeah, Colorado has a similar state system. It's our standing order system. Actually, my brother and I believe are both registered in it through our local public health agency, and we would bring sometimes dozens of boxes of Narcan home in the back of our trunk and go and park outside of a football game and just throw it at people until they listen, basically. Usually we'd run out incredibly quickly because students would want it. For our school district, it was a very similar process for them. I'm not sure if they either did it directly through the state or through a local public health agency, but I'm incredibly fortunate to live in Colorado, where we have a very robust standing order system that includes fentanyl test strips. I do not, which is now included in our legislation as well, for students to be allowed to carry. For Colorado, I would hope to see more states adopt a more robust standing order system. I'm now a student in Virginia, which has a standing order system, but there are more regulations and more concerns about the permanency of that funding, which I think speaks to what you're talking about earlier, about how harm reduction must be seen as a more medical issue than a political issue. And unfortunately, it's being framed in a political light so often.
Absolutely. Thank you so much. This is sort of a good question for both of you. I'm kind of going to combine two questions here. What do you think is the best way to connect with youth in our communities? This question comes from someone who says they have a lot of organizations that work with youth at the table, but have been slow to get student advocates involved. And someone else asked specifically about the student ambassador program that you had mentioned, Dr. Kapunan. So I'd love to hear from both of you what you think the best way to get youth involved is.
I think that's something that we're still working on in a county as large as ours, to make sure that all youth have a chance to be part of the process. We have a strong tradition of youth leadership. We have a voting student member of the Board of Education, and they do incredible work in terms of making sure students have a voice at the Board of Education policy table. I mean, that's something that we've had for a long time. But when we had these huge forums, we had them in various parts of the county and invited everybody to come. So that's part of it, like giving them the opportunity to step up and making sure that everybody knows that there is the opportunity to get involved in a formal leadership way. But also a lot of it is on the ground talking to kids at the high school. So, you know, I was saying in the adolescent substance use prevention groups, there would be like a table at the cafeteria at lunchtime, and having these opportunities for informal discussions and support at the school level. In our high schools, we have youth development specialists who interact with schools, with students on a daily basis. So some of it is just doing the on the ground level work in terms of letting kids know that you're there. And this is something that we talk about.
I think something we've seen for youth engagement, I guess for us, our experience was less how do we get youth engaged and more how do youth kick down the door and make sure we're being listened to? How do we get into those rooms? And I think one of the most important things is allowing people an avenue to be involved with their education and to have, I think, student board members. I was a non-voting student board member before I was involved with harm reduction. It was an incredible learning experience. But that goes for any decision-making committee or group at a school district level. If you are involved in education, pull students in, make that available because students will want to engage with that. I think more towards the how do you create student involvement. I think schools are an incredible place to start. There are also other organizations. I'm thinking in Durango, we have Young People in Recovery, but other groups in the community where they have youth engagement and kind of opening those doors and helping get more youth involved in that. But really for schools, it's you need to, and this is the challenging part, and I don't know if there's any one perfect answer, but it's creating spaces where youth feel safe to share their lived experience. Because unfortunately, the place where the drug supply is and the place where drug use is in our country, the vast majority of students, you know, even those who are non-users, will have lived experience, whether that be friends or peers overdosing, being concerned about their supply being laced or suffering from addiction. And that's something that many students are very concerned to share, especially when they see a more reactionary punitive system. So it's both creating a disciplinary system and a space where students feel safe to share their experiences. And I think once that happens, students will be, you know, want to be involved because it is an issue people care so deeply about.
I would add one thing, and I mean, I agree totally with everything that you said. An area that we need to grow is peers in recovery as a means of support and mentorship. You know, it's a delicate group to engage in terms of where they're at with their own recovery, but in substance use in general, peer support, peer mentorship, peer coaching is a powerful model, and it's a particularly and uniquely powerful model for teenagers and young adults. So trying to understand how we can listen to all youth, but especially those in recovery with lived experience who are ready or interested in sharing, supporting, and mentoring, I think would be incredibly powerful.
Thank you. Thank you so much. I noticed a couple questions on this, and I'm not sure if you will have anything specific to add, but the question about some of the things I mentioned about sort of upstream prevention efforts like Housing First and Guaranteed Basic Income and addressing those social determinants of health and how they are an important part of reducing overdose. I know that there's a lot of research about how the structural determinants of health and how they impact people using or not using drugs. But in terms of like in schools, do you have anything to add to that you know, I mean, to me, it's hard for me to explain because for me, it just seems to make very clear sense that wealth inequality, structural racism, and other social determinants of health have such a big impact on whether or not people are using drugs or not. But maybe in the school system, do you see that playing out? And is there anything you can offer to that conversation that isn't out there?
So we see it playing out. The idea of social determinants of health is a new one in the educational realm. The National Center for School Mental Health, also here in Maryland, talks about social influencers of health and education, because when you break them down, they're very similar, right? Health is very linked to educational outcomes, and then the various social determinants, almost all of which are driven by racism as a root factor, in addition to other factors, influence how kids show up in that space. So making the direct connection, I have to ask, like, why what is the purpose of making the direct connection? I think schools are starting to make that connection as they look at racial disparities and academic achievement and understand that Maslow's hierarchy, people may be worried about X, Y, and Z before they're worried about J. So I think what I had shared before about schools creating community and being the places, the trusted places where families can understand so what's available to them, and we can know them and understand what their needs are and connect them to supports, and understand that children come from families and they're parts of communities, and if we wrap that all together, they will do better, right? So those things are not just things to prevent risk behavior related to substance use, but those things are things we do as a community and as educators, because it affects how kids show up in schools. It affects how our staff show up in schools, and our community responds to and cares for them. So, I mean, all of that is very foundational and essential, and you don't need to make the connection to substance use to do something about it. I hope you don't.
I agree. Hayes, do you have anything you wanted to add to that? Or I have another question for you. What about, I'll start with Hayes this time. What about other staff in schools, and what they can do to support harm reduction efforts, such as school nurses or counselors or resource officers? What do you think that their role can be, and how would you encourage them to go about increasing harm reduction efforts in school?
Definitely. I think this is a challenging question to address because, we have a school system where we have educators and people in positions of power who are, in many cases, mandated reporters for drug use, I think is a good example of this. So it's looking at how do we kind of create a more conscious culture regarding this. I think school resource officers stood out to me as an example. Our school resource officers at my high school carried naloxone for a long time, because a lot of times law enforcement officers actually want to carry it. I now go to the University of Richmond, where I think on my first day, I was like, hey guys, was asking one of the cops at a tabling event, what's the legality in the state of Virginia and on this campus? Are there policies I should be concerned about if I'm carrying Narcan or giving it to others? And the guy's first response was, oh, do you want some? I have some extra in my bag. So I think something is we see a lot of these people who interact with students want what's best for their students, and oftentimes have a very strong understanding on the ground of what's happening. I think that goes back into pulling, more people into the conversation. Is oftentimes school resource officers, if they're in a program which seeks to build community with students, which Durango fortunately does have one, know a lot about students' everyday lives and are trusted individuals. And the same goes for therapists and nurses, and athletic trainers is a great example from, at least in my high school, because I was very close with our athletic trainers. But it's how do we seek to pull in people who interact with students every day? And these are also great examples of ways that you can pull in students. Is if students have trusted adults who they look up to, those adults can help bring students to the table and help bring students to the conversation. This also goes back to education curriculum, which I know I touched on before briefly, but we need to look at the education that we provide students on drugs. Like I said earlier, a lot of students are still receiving this very reactionary, somewhat rather racialized, rather class divided drug education from the war on drugs. We had someone ask, whatever happened to Officer McGruff when we were attempting to push for Narcan? And we're like, well, it failed, right? There's a new study I was reading that saw that California students who did DARE have a higher rate of drug use than those who didn't receive any education. And it's how do we look at education as still preaching the values of abstinence from drugs, recognizing that is not the reality for a lot of students. And when we turn our back on those students, that's when those students become more isolated, become more pushed away. And it's harm reduction and teaching, and looking at these trusted adults we're talking about and seeing how we can use education as a way to pull these people back in. And that's compassion, that's harm reduction, and that's recovery. That's something we saw in our own district and with students, who we're working with, is when we are distributing naloxone or when we're having these conversations, students feel more comfortable entering recovery methods. We saw, some of these groups in our community like, wow, we have more students than we've ever had before. And part of that is because it allows them to see that there are merits to this public health system. There are merits to harm reduction. And it's how can we build trust and how can we pull these students in and show compassion and care and recovery?
Yeah, and I know that trust is a really big thing. I've spoken, I grew up in the 80s and I definitely went through DARE programs and things like that. And myself and my friends and many people that I've spoken to um, found that when you're given this one-sided training without any reality, and then you find out the reality, um, it makes you lose faith in adults. And I think maybe losing faith in adults is part of the growing up experience, but in this particular area, we want our youth to be able to come to trusted adults and with these issues um, and in order to seek help. So if we're just lying to them as they're growing up, um, they're going to find out, and then that's going to be an issue in the future. Um, I also noticed uh, Dr. Kapunan answered in the chat about how what age would be good for teaching students about naloxone. Um, and she mentioned that the county, there's no age limit on the standing order, but that the county trains and distributes to kids 14 to 15 with parent permission and 16 and up independently. It's important that developmentally kids understand what else needs to happen in response to an overdose. That's a critical part of naloxone training. And I think that understanding the entire situation is absolutely needs that sort of level of maturity. But I would say in terms of like younger children, if they're living in a home where there are people who are at risk of overdose, it's an easy thing to do. And it can be just as simple as teaching them to do that, as well as calling 911, which they're probably already being taught how to do. I'm so sorry that it's coming up on 2 o'clock and I want to be respectful of everyone's time. And I know we didn't get to every question. Again, I'll put my email in the chat, and if you need to get a hold of me or any of our panelists, please feel free to send me a message. I want to thank you all for being here. Thank you, Liz. Thank you, Kayleen, for hosting. And thank you so much to our guest speakers, Dr. Kapunan and Hayes Stridicus. Thank you so much for everything that you've done and for being here today and sharing it with us. Again, there will be a recording of this webinar available in a few days, along with the slides that we had today. And I hope everyone has a wonderful week and a nice holiday as well. Thank you so much.
Thanks so much for having me.
Thank you.